Yeah, well, once again, thank you for giving the honor of inviting, giving me the honor of being invited to do this, and I'm always happy to do it at any time. You know that. Um,
Yeah,
I know that this is probably a fairly mixed audience of maybe people who are old hands or people that are new, but I hope that there's something in it that is of use to everyone's knowledge, as revision in some cases and as new information in others. And I just want to say that Dr. Ismail and I, my boss who runs the service here at the Royal Free, we're always saying how we love doing the transplant dermatology clinics. It's a bit of relief to us on a heavy week because those clinics are actually much easier, and that's to do with the patients. So it might be useful for you to know that. It's always a pleasure to see the transplant patients, and it's something that we enjoy doing.
thank you.
That's okay. A lot of skin cancer is to do, as you know, is to do with risk. So having had a transplant and taking medication is only just a part of it. There are other factors that come into play. And I think one of the most basic factors is your actual skin type. Some people, if you look in textbooks or on the internet and stuff, sometimes they I think they slightly misquote it, but anyway, they talk about burns easily, burns then tans, always tans, or etc. I think it also helps to think of Fitzpatrick skin type as a sort of global distribution. So skin type 1, which is the most one that is at highest risk really, is usually very northern European, red hair, very pale skin, usually freckles, of Celtic origin probably, northern European, and they are the highest risk. Type 2, I always say most European Caucasians are probably a type 2. Type 3 is more sort of like Southern European or Latin or South American, a little bit more protection because there's a little bit more melanin there. 4 is sort of Middle Eastern skin. 5 is Asian Indian, and Chinese skin is 5. And 6 is Black Afro-Caribbean skin. And of course, these are gradations of risk, but no one is completely without risk. And this is the same in the normal population as well as the transplanted population. As you go up the scale, you're more protected, but no one is completely protected. And please do interrupt me as I go along if you wanted to ask anything or if there's any points about the slides. These are the other risk factors. So we talked about skin type, but the other risk factors play a large part, and it's sort of principally your sun habits prior to the time you were transplanted. As a child growing up, what occupational exposure as well, and if you've always been a bit of a sun person. The duration of time since transplant comes into play. So the risk starts, that they say, the literature tends to say at about 5 years after transplant is when the risk sort of starts to come into play and increases each year. And of course, as we know, probably one of the principal risks, certainly from what we have to look at in the clinic, is the type of medication and the dose of immunosuppressive meds. And of course, the good thing is that by and large, for a lot of people, thankfully, those doses come down with time. So as the years from transplant go on, and in a sense the risk increases, that's balanced a little bit by the doses of your immunosuppressive medication often being reduced or sometimes changed if the drug causes an issue. In our organ transplant, in our immunosuppressed clinic here at the Free, we don't just see kidney patients. We do see, there's a few heart patients. There's quite a lot of liver patients, liver transplant patients, because as you know, the Royal Free is a big liver transplant centre too. People may know the answer to this. Heart transplants are pretty low risk. Liver are considered moderate, and kidney are higher risk. And does anyone know why that is?
No.
It's to do with the medication. Unfortunately, you're on the highest doses of immunosuppression. That
Really?
organ needs the most support. So kidney patients are in the highest risk stratification for skin cancers after transplant. But I must say, and again, I hope people know this, and I always say this to people at the very beginning, especially to new patients, the skin cancer can, by and large, be treated pretty simply, quite straightforwardly, usually by surgery, sometimes by topical creams or other things. But these things are treatable. It would be nice not to get them, but they are by and large treatable. And that's one of the reasons why we do our clinic, and why, you know, it's Department of Health guidance that you have these clinics. If you are a big dermatology centre and you have organ transplant patients, that you provide the service. You know, it's laid down, and that is because you can either help prevent, educate, or treat. And as I say, they can almost always be treated pretty easily. So here we have the meds. They're in no particular order. I think people mostly tend, I mean, the top two drugs are the most commonly used, certainly in the renal patients, sometimes with prednisolone as well. But you do see a bit more of cyclosporin and sirolimus sometimes. Does anyone know which of these drugs we don't like? Azathioprine, unfortunately, we don't like that much in dermatology. It's not just used in renal transplant. There are quite a lot of patients who have things like Crohn's and stuff, the gastro patients who've been on azathioprine for years and years and years. And sadly, they've never been told about the risk of it. So a lot of people missed out on the sort of protecting themselves in the sun, who really should have done. We've been told. We do see a lot of those gastrointestinal patients now, though. Azathioprine is a bit of a tricky drug, although an effective drug. It's quite an old drug. It's been in use in organ transplant for quite a while, for years and years and years. Unfortunately, as well as being an immunosuppressant, it's a photosensitizer. So it's a sort of double whammy. It makes you sensitive to light as well as reducing your immunity. So ideally, it would be good if you're not on azathioprine, but I understand that some people are and that it works well for them. And at the end of the day, the graft is the most important thing. I did this sort of chart when I was trying to explain skin cancer to a different group. It's a sort of stratification, and of course it doesn't mean that you go through these steps, but these are the steps in certain types. I don't know if you know, we divide skin cancer really into two parts. We talk about melanoma, which is the most serious and significant type of skin cancer, and then we talk about all the others. So there's two groups, the melanoma and non-melanoma. And in non-melanoma, one of the most simple things are in the middle there, you can see actinic keratosis. So that's just sun damage, really. This is when you get like a little bit red, a bit flaky, maybe on the scalp or whatever, or on the nose and face, places that are exposed a lot. And actinic keratosis isn't skin cancer, it's just a precancerous change in the cells. It doesn't mean it's going to do anything, and it can be treated, but it doesn't look very nice. Some people find it sort of unsightly or uncomfortable as well, and you can treat that. There are creams to treat that, which we do use. Sometimes that progresses into the middle thing, Bowen's, which is a little bit more pronounced. And sometimes, again, it's not necessarily a follow-on step, Bowen's would become a squamous cell. And it's the same for BCC. You can get a superficial, there at the top, left-hand corner, you can get a superficial type of BCC, which is basically flat on the skin, and you can treat that with a cream, the same cream that you would give for actinic keratosis. Sometimes, but not always, if left, it would progress into a BCC, which is also not dangerous. A BCC is not a dangerous cancer, and I'll talk about that more on another slide.
What does it stand for?
Basal
Please?
cell carcinoma. Sorry, you'll have to correct me because I'm always used to using these terms, aren't I? And they're sort of medical, but they're so general. Everyone
No, basal
in our
cell
world
carcinoma.
knows what BCC means. You have to remind me. Basal cell carcinoma. It's the most common cancer in the whole world.
Right. Okay.
The most common
Thank
cancer
you.
in the whole world. 1 in 4 people get these in their lifetime. I'm talking about the general population. And a BCC, it's so common that it's not counted for insurance. So if you're filling in a travel insurance form or something, and it said, have you ever had cancer and you've had a BCC, you can say no, because it's not counted. It's too common. It would skew the data. And I tell you that to put it into perspective, because it's not that serious. You know, it's not. But it's just an annoyance because you have to fix it. And then at the bottom there, you've got melanoma in situ, and then melanoma. Superficial spreading is a general term for a melanoma, and then metastatic melanoma that has spread. A melanoma in situ is literally a bit like the other two things in the other staircases, the really flat kind that's just very confined to the top surface of the skin. So it's early. And you take that out, and to put that into perspective, if you find someone with a melanoma in situ and you excise it, you discharge them. You don't have to follow that up, because it's really, really, really just a very severely dysplastic mole or something, but it's called a melanoma in situ. In the middle there is melanoma. That's the most common type of melanoma you get. It's called a superficial spreading. It just means it's spreading on the top surface of the skin. It doesn't mean it's going anywhere. And then metastatic melanoma is melanoma that is spread to other organs. Now, I must say, we do not see melanoma in transplant patients very often at all. We really don't. I've been here for 12 years, and in that time, I have seen 2, which 2 patients get with melanoma in the transplant population. That would match the normal population. So it's odd. Melanoma doesn't seem to occur very often, which is a good thing. The one that, does anyone know which is the most common type of skin cancer that you see in a transplanted population?
Squamous cell?
Yes, it is. Exactly. So in the normal population that's not, everyone's normal, but in the population that's not transplanted, BCC is the most common cancer in the world. But in the organ transplant population, you tend to get SCCs. Much more, it outweighs them. So does anyone any ideas why that might be?
Alan,
Yeah.
what does BCC, is it? Is it British Common Cold?
Yeah, I know.
No,
basal cell carcinoma. So BCC, it's SCC and BCC are skin cancers, but it derives from the cell they come from. So a basal cell is a very simple and bland cell in the skin. A squamous cell is a different type of cell, but they arise from those cells. But a BCC is the most common cancer in the whole world in an ordinary population. In a transplant population, we get SCCs more. And the reason for that is probably that SCCs are possibly immunity driven, so they can be virally driven, that sort of thing. So they're totally different to BCCs. It's a different strain. It's a different stream. Does that make sense?
Yes. Yeah. Yep.
And they're more likely to be, you see those in people who have their immunity is lower. And so they're probably driven a bit or encouraged by lack of immunity. A bit like you get viral warts, because viral warts can be closely related to a squamous cell carcinoma, which is why we're always a bit precious about a wart. We always have a look at it, and because they can progress into something if they're left. That very rarely do, but they can. I'll move on from this one. Okay, so here we go. It's a BCC. There are 2 main types of skin cancer. Melanoma, that's what I said. BCC is the most common type of all skin cancer. It's more than 80%, like I said. So, and sometimes you hear, I hate this term, but they used to be called rodent ulcers.
Oh, yeah.
I think people called them that because they didn't like saying the word cancer, which is often, now that we're a little bit less finicky about things like that in medicine. The commonest cause is too much exposure to ultraviolet light from the sun or from sunbeds. Over years, it's cumulative exposure. It's not just getting sunburned a couple of times. You know, it's little bits of sun exposure over time. They can occur anywhere on the body, but they're most common in areas that are exposed to the sun, such as their head or neck. And of course, that makes things tricky because you want to cut something out on the body. It's quite easy, you know. You're going to leave a scar, but people aren't so finicky about scar on a place where you wear clothes. But taking something out on your face, that's different. So, and unfortunately, BCCs do occur a lot on the head and neck because it's the place that we expose to the sun the most. SCCs, is one of the it is the second most common type of cancer after BCC. Again, it's ultraviolet lights or sunbeds. We talk about keratinocytes. Those are the cells that can change and become an SCC. Again, they can appear anywhere, but it's far more likely to be the head and neck. And strangely enough, they can, but you don't really see this much. They can crop up on areas that have been damaged by x-rays or stuff, or even old scars or chronic wounds, which is why with leg ulcers, you always have to be a little bit cautious that it's an ulcer and not a squame. You sometimes have to biopsy them. Melanoma. Okay, so we don't like melanoma. That's a tricky thing to treat. It's always been very difficult. But as I said to you, we don't tend to see melanoma in the transplant population at all. We don't, which is a good thing. It comes from the word comes from melanin, which is the pigment in our skin. Melanocytes are the cells that lead to melanoma if they start to grow unchecked. They grow together in harmless groups of clusters. That's actually what a mole is on the surface of the skin. It's a big clump of melanocytes, and part of that is just inheritance. You know, if maybe both our parents were moly, we'll be moly. But melanomas don't necessarily come from a mole. They can come from a mole, but they don't necessarily. In fact, only about 20% of melanomas arise in a pre-existing mole. A melanoma could literally just evolve on the skin where there was nothing there before. Does that make sense? Mm-hmm. And fade the skin around and get a little bit bigger, and they sort of go downwards. And then if they're around for a long time, then they can go to lymph nodes and organs. I'm sure most people on this talk know about this organization. And if you don't, I can say they're very good. And there's a website here you can see, Bisky. And they have a lot of good information sheets that you can download from their website on the risk and what to do. Mm-hmm. I'm showing you this because we didn't write the rule book. We work with other people. Catherine Harwood is the professor at the Royal London, and transplanted skin is her main interest. She's done almost all the trials that have been in the last 15 years, looking at new treatments and stuff, have been from Prof. Harwood. She's a very nice lady. And she stratified, when we follow up people, it's not just random. It's been stratified about how we should follow up people, and we follow her stratification. You can see it here on this document. It's a bit small, but basically it's looking at, as we said before, skin type, whether they had a certain amount of, the person had a certain amount of occupational exposure prior to transplant, recreational exposure, lots of sunny holidays, if they use sunbeds, and what medication they're on, and also their age. So, and obviously, I know that some of the transplant population have had more than one transplant. That comes into play. You can see that at the top. So we tend to follow her guidelines because it makes things easier. Most skin type 2, so like I say, European Caucasian skin, we tend to follow those up yearly. Type 5 and 6 skin, in theory, we should be able to not see them so frequently because their risk is lower, unless there are other factors. type 1 skin, you would definitely see at least yearly. But if someone has had a skin cancer, a squame, or a couple of squames, you would probably see people like those 6 monthly, which is what we try to do. I'm going to show you some pictures now. I hope people are all right with looking at pictures. I don't think I've got anything like really yucky, because sometimes when you go on medical sites, it's not pleasant sometimes, and I hate that. But these pictures are pretty bland that I found, and I just wanted to give you an idea of the how tricky it can be sometimes for the clinicians, let alone a patient, to know, well, what is this, and should I be worried about it? If you look at these two pictures, which, just out of interest, do people think is more likely to be the skin cancer, the left or the right?
Right.
Left.
The right. You think left? Yeah. I mean, the picture on the left, the quite prominent nodule, is actually benign. The picture on the right, I think, shows an amelanotic melanoma. So not all, as like I said, not all melanomas are moles. Some of them are pink. But I must say, and again, I stress this is really unusual. This doesn't happen very much at all. And that's good, because it would be quite hard to pick up, because it looks quite bland, doesn't it?
Mm.
Obviously, in medicine, you go by other things: the history, if they've had a lot of sun exposure, the skin type, when was it not there, has it changed quickly, that sort of thing.
Can I ask a question quickly? How would it appear on the black skin? It won't appear as pink.
You're 100% right to ask that. Yeah, it's tricky. It's a tricky one. And do you know where the most common area of black skin to get melanoma skin cancer?
No.
It's on what's called the acral skin. So acral skin is our palm and our feet, the soles of our feet. It's the skin that has the ridges, that make prints. Acral skin is, in type 6 skin, acral melanoma is the most, you don't see melanoma very often in organ transplant patients. You certainly don't see it very much in type 6 skin, but when you do see it, it tends to be more acral, so hands or feet. And the skin on the hands and feet is lighter, so a pigmented lesion does that answer your question?
That makes sense. Yeah.
Which is why, I mean, I don't know, other people who examine people are all different. If you're in my clinic, I always look at people's feet, because I think it's really important. The soles. Okay, I've got on the screen, I've got some pictures of BCCs. Can you see the 3 at the top of BCCs? The 3 at the bottom, those are squames. And can you see the on the left at the top have got a distinctive feature? They're quite shiny, aren't they? Can you see that? They call that pearlescence. It's almost like nail polish. And being a picture of BCCs, they often come as little ones like this that are shiny and intact and really, really slow growing. You could have this for years before you could even see it. And like I said at the beginning, this is not dangerous. So it doesn't matter too much if it's been around all those years, because it'll never do anything. You still want to take it out to stop it growing more, but it's not dangerous. On the right, there's a pigmented variety. Can you see? Now, to an uneducated eye, that, a non-clinical eye, that would look a bit scarier, but it's still a BCC. And if you look at it with a dermatoscope, those little tools that we use, like a light, we can tell that's a BCC, and we're not worried about it. We just arrange to have it taken out routinely. The ones on the bottom, they're different. Those are squames. You don't want to leave those. You want to get those out reasonably quickly. And they grow quickly, so they might not have been there like 5-6 weeks ago. Does that make sense? Which is why we're always asking people, how long has this been there? Is it tender? Squames tend to be tender. They're not always tender, but they can be. Whereas all other skin cancers are not painful. These even look a bit tender, don't they? I'm sure you'd agree. They look a bit sort of angry. And what's on the top in the middle, that's keratin. It's like a sort of dressing that your skin puts on something to protect it. That's all. And like I say, these grow quickly. This can be not there and there like this in 4 or 5 weeks. And again, it's almost always exposed. So moles, these are moles. I just thought I'd show you, because I think sometimes people don't really know what you're talking about when you talk about moles. I think people think that everything on your skin is a mole. It's not. A mole is a pejorative term, so it's a sort of almost a slang term for these nevi that are made up of the melanocytes we were talking about earlier on. So the pigmented melanocytes, and they can be totally different. So you get the flat ones, which are it says they're called junctional because they're at the junction on the skin. They're totally flat, and those are the most common. Flat moles, brown moles. Compound is a bit bumpy and a bit flat, a bit of both. And intradermal are the bumps. And sometimes intradermal, in fact, mostly intradermal nevi are flesh-colored, so they just look like flesh-colored bumps. But they're totally benign. In and of themselves, they're totally benign. People, worry about moles, especially if they change. But if they change slowly over years, that's not worrying. If they change rapidly over months, that's something that should be looked at. On the bottom, you get some of the sort of oddities that you can get in. We're human, so we have the whole gamut of things on our skin. A congenital nevus is what we would call a birthmark. Yes, and you've seen these. You've probably seen these on people. Sometimes they're even hairy. Yes, this is fine. It's just a birth. People call it a birthmark. There is no such thing as a birthmark, really. It's a slang term. Congenital nevus. In other words, you were born with this. It wasn't present at birth, but it became more obvious as you grew up. And this is benign. This one in the middle is one of my favorites. It's quite funny. When you see it, you never forget it. This is one mole. It's called a spilus. Lots of little dots, but it is just one mole. And this is how it presents. It's benign. And can you see on the right, the Beckers? They're huge. Sometimes they will cover a whole torso. It's a birthmark. It's a mole. And it's big. Not all moles are little things. And it's totally benign. Does that make sense?
Yeah.
And sometimes they've got a little bit of hair. But moles can come in all shapes and sizes, basically, is what I'm saying. And
Alan, can I quickly ask a question?
yeah.
Regarding the natural nevus.
Congenital, yeah.
Yeah, the birthmark, I would say.
Yeah.
How come twins have identical ones?
Yeah, good question. Have you seen twins with identical ones?
Yeah.
You have? Yeah, good question. They must have been, the same zygote twins within the same cell, because the skin has developed exactly the same way. It's a kind of miracle in a way, isn't it?
Yeah, it is.
But the good thing to know is congenital nevi rarely do anything. They rarely go rogue. They rarely turn into anything. In fact, of all these 6 on the screen, can anyone guess which is the most likely to transform? It's the junctional one, the most common, the ordinary flat mole. Bumpy mole, people always think a bumpy mole is problematic. Not. They rarely tend to go rogue. It's flat ones that go rogue the most. Okay, let's go to our next slide. I wanted to just show the other things that it's not all about skin cancer, transplant skin, as you may already know. There are lots of other things that can happen to immunosuppressed skin. So you can, even if you never had acne in your life, you can post-transplant get acne. Folliculitis on the right, that's sort of an inflammation of the hair follicle cells, which sometimes you need antibiotics for. You can treat this. You can treat this topically by using medicated soap, etc. But sometimes you do actually have to give antibiotics. On the right there in the middle, you can see a fungal infection, which are often itchy, but they're not always. And sometimes you can get it on the back. And it makes it look like your skin has gone pale in certain places. That's called pityriasis versicolor. Again, these can be treated with just like an antifungal soap or something like that. But it has to be used consistently. In the middle there, can you see at the bottom the little bumps? Now that could be BCCs, couldn't it? They look a little bit like bumps we were looking at earlier on, but you don't get clumps of BCCs. You just get one. So if you have clumps of something, it's almost certainly going to be something benign. And this is benign. These are sebaceous glands that have just become enlarged. Hyperplasia means made bigger. Does that make sense? And what they are, they're oil glands, that's all, that are working overtime. And if you lifted 20 kilograms every day with your right bicep, it would get bigger than the left bicep. And that's what's happened here. The oil glands are working overtime and they've enlarged. Tacrolimus contributes to this, unfortunately, because it does make skin more oily. And you can see, and it can be quite, it can be quite marked. The picture in the middle on the bottom it's quite marked. The picture on the left at the bottom is a little bit more subtle. Can you see? Yeah. But if you have groups of something, it's going to be a benign thing. It's not going to be a skin cancer.
Does it have to be there permanently, or it comes and goes?
No, well, I think they tend. I mean, I think if it started coming and you were really good about maybe using an anti-oil cleanser, definitely not using an oil-based moisturizer, and your immunotherapy came down, your immune drugs, the DOE, then it would probably not get any worse. Put it that way. You can also treat it a little bit by, I mean, sometimes if they get really big, you can cauterize these, and they do sometimes go away and never come back. But it is a tricky thing, sebaceous hyperplasia, to treat. It is. I thought I'd put up some questions which are sort of like maybe common fallacies, but maybe you can correct me here. I could be totally wrong. A suntan can protect you from skin cancer. Do people think that?
Nope.
No.
No, good. This population shouldn't. No one's. But I still do get this from people who should know better. No, a suntan doesn't protect you. In fact, a suntan is damage. It's your skin protesting.
Can I just ask? My neighbour next door is black. He comes from Antigua, and he said to me that black people need more sun or can take more sun on their skin.
Well, I mean, no one really should be inviting it.
But he's always out there. As soon as it's out, he's out there without his shirt on.
Risk is lower than mine, significantly lower, but it's not zero. And the thing is, we don't really understand a lot. I mean, this proves that we don't understand as much as we think we do. For example, in melanoma, as I said, in black skin, you often get that on the sole of the foot. Now, who sunbathes with their feet up in the air? No.
Women do.
Do they?
Some women, yeah.
Melanoma, there's more to melanoma than the sun, basically. There must be, because there must be other genetic or environmental contributing factors. Poor Bob Marley had a melanoma on his sole of his foot. That's what he died from. Because he didn't want to have the surgery to remove his toes because he liked playing football. And he's probably one of the most famous people in the last 25 years who had that. And if you go onto the internet, you'll see his image if you do a search for acral melanoma. But yeah, I mean, your neighbor is right to a certain extent, but I would never encourage people to cook in the sun. It's the sun can be enjoyed without it enjoying you. Does that make sense?
Yeah.
I think.
Yeah, I'll tell him that.
Melanoma is melanoma skin cancer. Now remember, melanoma is the very severe skin cancer. Let's keep this in perspective. And like I say, it is unusual, still unusual in a transplanted population. I don't think their risk is any different from the normal population. People do think, is melanoma skin cancer incurable?
No.
Probably not, actually. It probably is curable now because we have a lot of we cut things out and that's usually the end of it. If something goes to an organ, there are drugs to treat that now, which we didn't have 15 years ago. So things are changing. Chemotherapy is a known treatment for melanoma. Yeah, you don't use chemotherapy for melanoma or radiotherapy for that. So they're not, melanomas aren't radiosensitive. You can't use radiotherapy or chemotherapy because we have better drugs now anyway. Is this true or false? Well, you'll know the answer to this if you've been listening up to now. BCC is the commonest cancer in the world. And luckily, it's the simplest and least dangerous. So that's quite good that it has those two things. People with Asian or black skin do not get skin cancer. Is that true or false?
False.
Yeah, it's false. Factor 50-some percent is the only protection that you should use. I wrote this, and I'm looking at it now from a sort of more objective view. I realise that it's a bit of a double whammy question. There isn't anything else besides 50. 50 is the highest that we still have. You will things that say 80 or 100. It's not real. It's not real. There is no 100. 50 is the highest we have, but I wouldn't say that 50 on its own, as this sentence reads, is the only protection. The protection you should use is covering up as much as possible, limiting time. So limiting time and covering up. Everyone likes the sun, of course they do, and they like to feel it on their face and they like to feel the warmth. But you just have to be super careful and not seek it out deliberately. Enjoy the warmth in the shade, basically. If you use sun protection all the time, you'll be low in vitamin D. It's actually been proven to be not true. You will, under the normal, in the summer months in Britain, you will still get, if you're out and about enough, you're an active person, you will get enough vitamin D in that way. But at the same time, of course, you can get vitamin D off Amazon and take from April to September and take, 20 milligrams a day and you'll be fine. I think I'd rather get my vitamin D out of a bottle. Yeah, than risk. Children do not get melanomas. Is that true?
No, it's false.
It is false. Luckily, it doesn't happen very often, but it does happen, but it's extremely exceptional. And of course, that is another clue to what generally most skin cancers are about, cumulative exposure. So not just melanomas. So a child will not have had the time to cumulatively gather all of that light exposure. Yeah. A tanning bed is safer than the sun.
I'm not sure about this one.
Definitely not. Not safer than the sun. Not that the sun's great either. The sun is a great big tanning bed, isn't it? It's the biggest one that exists in the whole stratosphere. But controlled tanning beds are lethal. They really are. It's delivering a very strong dose of UV light in an enclosed area to usually, virgin skin that hasn't. People go to tanning beds. I'm going to prepare for my holiday, the end of the winter sort of thing. No, it's not. A tanning bed is not safe, and they should be banned. One kind of skin cancer can turn into another. What do you think?
Yeah, probably.
They can't. No, I mean,
wrong.
It doesn't work. Skin cancers are actually quite straightforward. So just to recap, the most common type of skin cancer that an organ transplant patient is prone to would be the keratinocyte one. So that's actinic keratosis, Bowen's, and maybe squamous cell. The other type of skin cancer, BCC, is it can occur as well, but only because it's the most common skin cancer in man. And they're all caused by cumulative light exposure over years. You can do your best, even after transplant, even if you've been a bit of a sun person before, by protecting yourself and taking just normal, sensible precautions, limiting your time, lots of factor, covering up as much as possible. Your risk does go up every year after the transplant, but it doesn't really start till about year 5, to be quite honest. And almost all of these lesions that we've seen are all treatable. All treatable. I can't remember. Those are my again. Those are my details there. You've got my number at the Royal Free, and we're always happy to be contacted by people, with advice or whatever.
Yeah. So, Alan, a quick question.
Yeah.
After transplant, if people I love my hot water. Yeah. So if I use very hot water to bath or shower, will it have effect on my skin?
No, not at all. Just don't burn yourself. That's all. But no. Those things. That's all totally fine. There's no risk there.
And how can we access the clinic?
Okay, so I should have said this from the beginning. Most people are referred. So we don't see every single person in the transplant.
No, I've looked at his picture and I think I've seen him. I think he actually was one of the ones who treated me.
Yeah, we don't see everybody. He's
really good.
Sounds quite young.
Automatically, we don't see everybody. They have to be referred, and most transplant consultants do refer after a certain period of time. Most of the referrals we get are to do with just for monitoring, but we occasionally do see people who do have we haven't seen them to begin with, but we now have a skin issue, and they get referred for that, and then we carry on seeing. So you need to ask your transplant nurses when you see them. I haven't had skin assessment. Is it possible? They will contact us. That would be the easiest way. But most people are referred eventually.
I thought as transplant patients it was automatic.
No, it's not automatic. In a way, you would think so, wouldn't you? And
I certainly seem to be pushed.
At the end of the day, it turns out like that because virtually everybody does come, but it's not automatic. They have to, 1, remember, and 2, there has to be a certain amount of time because your risk, once you've had your transplant, there's a lot of other things going on that you're stable.
It wasn't straight away because I don't think it was brought in straight away. I've had my transplant 18 years. So
back then there probably wasn't the service at all.
No.
But like I say, the risk doesn't start till about 5 years. The literature.
Yeah. So maybe that's why they.
A bit of a leeway. But if someone had a skin problem, after transplant, people often get things like acne and stuff, white gloss. So those are often just for assessment for that. But sorry, go on.
Alan?
Yeah?
What are the symptoms of Bowen disease?
So Bowen's they can be a bit tender. Like I said, squamous cell can be tender. No other skin cancers are tender. Bowen's can be a bit tender. It's usually like a sort of red flaky area or a plaque, and it can be quite thickened. It's certainly a lot more than just the actinic keratosis, which would just be a little bit of red flaky looking sun damage. Bowen's there's a bit more going on. It's more like a single lesion. It can be tender. It isn't always.
Okay, thank you.
Quite small.
Can I ask a question, Alan?
Yeah, of course.
I had my first transplant in 2014.
Yeah.
And then my second one in 2022.
Yeah.
And you said something about the risk is after 5 years or up. So is it why? Because I get seen every year.
Yeah.
But I can't remember if it was from the first transplant or
sure.
since the second one. I can't remember.
You haven't had anything, have you?
No.
No, well, that's good. So, you know, that you have to take that into account as well. The risk is probably pretty low.
Yeah.
Because, you know, it'll be based on your skin type. And if you've had anything, you know, if you've had nothing at all, that counts. That's good. And also, you're probably relatively low immunosuppressed now, I would hopefully. So
maybe.
Yeah. So those things all come into play. All of those factors that I talked about at the beginning are the pillars of the whole thing. Your time since your sun activity before that, your medicine and the dose of it, and whether the family history or a personal history of skin cancer.
Okay.
Those factors help.
Thank you.
Yeah. Obviously, skin cancer is the most important part of what we do. But as I said, the other things like folliculitis and acne and stuff, we can help with those things too, because they can be debilitating and, you know, awful to suffer, I understand. And, you know, I think I was trying to think that I don't know if you know, but this will be useful for you to know. We are going to be making a video. Dr. Harbour wanted us, he's got this, they've already made a few. One is for people, for PD, and another one is in low clearance. And I think they want to make a video that they can just send to patients as a link, you know, when people are being worked up for transplant, and it will tell them a little bit about skincare and post-transplant. So we are going to make a video, and we had to think sort of this format, and we had to think. They asked me to come up with some questions that we thought patients might ask, and I must admit the very first thing that came into my head was, can I go on holiday? And, you know, of course you can go on holiday. I think it's just, I mean, people just need to be sensible, don't they?
Yeah. Is it okay to use umbrella when you are out in the sun?
100%. Be great if people did, yeah. You go to somewhere like Japan,
yeah.
you know, and they have, because they have, you know, they're very fair, and it's a different culture, you know. People see sun. I always think about, it's kind of weird, you know, if you went back in time to the Middle Ages, people who were tanned meant you worked outside, you were a worker, you were, you know, of low status. And if you were of high status and lived in a chateau, you were pale and fair, yeah? And now, if you think about it, it's totally reversed. The people who can afford to go to Dubai and the Bahamas, they're the tanned ones, and the people are stuck, you know, it's the total opposite, isn't it?
Yeah. I've actually got a sunshade, a proper sunshade knee, and I have that because it's a total sunblock, because I don't like always wearing a hat.
Yeah, well, I think it's great. But also, you know what? And I come down to this at the end of the day. It's aging. It's so aging.
Yes. Yeah.
So it's really aging, isn't it?
Well, yeah, tanning is, yes. Yeah. Getting wrinkles, yes.
You know, okay, if we were put in a cardboard box with cotton wool around us from birth, we'd look very young, but we'd also wouldn't be very well, would we? So we do need to go out and about, and we need to get a little bit of light. We need to get less of it, everybody. Yeah.
Right. Thank you very much, Alan.
I hope it was
a very, very good presentation. And I believe all of us have benefited from this talk.
I hope so. Thank you.
We have taken a lot out of whatever you said.
Yeah.
And I want to personally thank you for taking out my skin cancer.
Oh.
Yeah. When you saw it, you acted immediately and took it out. So I'm very much happy that it happened that way.
It's nice.
And we need you to talk to us much more about the skin, because we get a lot of different illnesses from the skin, like the acne, eczema.
100%. I mean, maybe next time I can ask Dr. Ismail to do, because she could do one, because she's more of an inflammatory dermatologist. I mean, I'm a skin cancer person. She's both. So being a dermatologist, she's the person really for all the other things that happen with your skin, as well as the cancer. And I could ask her, and your next time that you have one of these, I'm sure she would like to, she'd be able to do that for you.
Yeah, we'll be very much grateful.
Getting more on the things that are outside of skin cancer,
Yeah. I pretty much like that,
I'll ask her,
Yeah. So once again, thank you very, very much.
Of course. And it's been so lovely to have here.
Yeah.